May I call on Professor Miltos Palidis. I would like to thank him for accepting our invitation first, and he will give us a keynote lecture about lessons learned in PRK and crosslinking.
Thank you very much for your kind invitation. This is, over the last 7 years, the 5th time I've come to Cairo. Always find something interesting in such a big and wonderful city. Last time I was in your new museum. It was really a remarkable place. Anyway, thank you very much. So what I learned, or let's say what we have learned with almost 15, 16 years of experience with a combined procedure like PRK crosslinking. First of all, we know that crosslinking helped a lot in making the corneas of the ectatic cornea stronger and stiffer, and we had a long-term follow-up with this procedure and the effects. One of these is that even 10 years after, the flattening effect keeps going on. And this is one issue that we will discuss today. Of course, the best and the most important result for crosslinking was the reduction of need of keratoplasties. And you can see that number from 2005, once this procedure was introduced, going really down by about 40% down to 2022. And this is a very important issue. What we have learned throughout these years was that almost when you do the standard technique, you have about 1.5 diopters of flattening. And this flattening is less when you do the early day transepithelial crosslinking, and I'm stressing the early day because at that time, transepithelial crosslinking was always almost the same as the standard procedure, apart from leaving the epithelium on. The flattening was less. Now we have modern ways to do transepithelial, and the result is almost equal, if not better, than the standard procedure. But we still need to reshape the cornea for two reasons. One reason is to improve the visual acuity, the best spectrally corrected visual acuity of our patients. And the other reason was to have them accommodate using the soft contact lenses instead of the most difficult and cumbersome lenses for keratoconus, which were very thick and square and hard. So John Kanellopoulos did the first protocol, the Athens protocol, and funny enough, his first case was not simultaneous, although after years he came up with a result where simultaneous was better than sequential PRK crosslinking. So John did it in an ectatic post-refractive case. We have also the Greta protocol from my friend George Kimionis, which was a PTK assisted crosslinking. Another huge step was the Bruce Allen protocol with the PRK wavefront-guided crosslinking. Then we had the PRK for heat setting, which was a customized PTK right at the area where you have the cone, and a very nice procedure, very well described procedure. Starix from another friend of mine, Miguel Rekiki, as well as Cosmo Mazzotta. And the last that I think Cosmo will talk is the new kind of wavefront-guided treatment using a totally different system, a ray tracing system, which basically is, again, a wavefront-guided, cornea wavefront-guided. So when you have a newborn method, what are the things that you want to have? You want to see the refractive outcomes. Of course, pain is one issue. If you can avoid it is good. If you can, then it's going to be something to discuss. The healing time and the haze. Those are the most important issues that we were faced in the procedure, in this procedure. And these are what we have so far as, for me, milestones for PRK crosslinking. That was the Athens protocol, where we were treating only 50 microns, and I stress that, only up to 50 microns ablation. And I still respect this rule. I don't go over 50 microns. The good thing is that with the new wavefront ablation protocols that we're using, you can treat more by ablating less, and that's a very good thing to start with. All these studies, as you can see, as here we have the study with the arteries, they were using different machines. So when you are actually evaluating a study of PRK crosslinking, you have to evaluate two things. First of all, what they were using to diagnose and guide the laser ablation with. And the second thing, of course, is the time. How much is the follow-up? So one lesson learned is check the laser platform, the diagnostic equipment, and the properties. How deep, the pattern that they use, and the refractive correction percentage. Because your aim is always in these procedures to normalize the cornea, to improve visual acuity, best corrected, spectrally corrected visual acuity by normalizing and reducing high order aberration, and not get rid of the glasses. If you can have both, in very few cases, you can do it. But the thing to have always in mind is to normalize the cornea. Mitomycin, another lesson there, and this is a very nice study by Shadi Wawad, where he showed that when he was using mitomycin, the amount of haze that you were getting with mitomycin was worse, was more than without. And that was evident both in a matter of intensity of the haze and also in depth of the haze. So mitomycin application after crosslinking, it increases the stromal haze, and that may play an important role in the final result, not only in terms of visual acuity, but what we're doing now in a study, we're comparing haze and maximum flattening. So far, this is anecdotal, I don't have it yet in a paper, we're looking for it, but so far I see that there is a strong relation between haze and flattening. And that's something which is not surprising. Now, tomography or topography. The topography-guided PRK foreign crosslinking in keratoconus, the simultaneous one, that was the Kimionis paper. He was using a topographer. Also, it was an eye trace. Then we have a more modern tomographers, and I think at the moment the most new result that we can have is with the IVIS topography guided, which is not exactly topography. That might, I think it was with Stojanovic, and now IVIS is moving to the tomography guided treatment. Of course, we all know that at the moment the topography and the value of changing the posterior coma is as much as important as well as changing the anterior coma. So it is very important to use the whole tomographic evidence instead of just the anterior surface, especially for the early keratoconus cases. Starix, it was another tomography-guided transepithelial PRK, a very important study from Miguel Requiqui and Cosimo Mazzota, where he was doing it in a two-step procedure in the same circuit. The first was epithelial removal, then maximum correction of coma, forgetting about all your refractive element, maximum correction of coma, and leaving it a little percent for spherical and cylindrical correction. Canelopoulos was saying you can limit by using the correction of 50% spherical and 75% astigmatism. And this was come out by a lot of studies that we're seeing that when you are treating a keratoconic patient, The astigmatic component is part of it, about 30% is due to the real astigmatism, and 30% was coma, and 70% was the astigmatism, the astigmatic effect. So it makes sense to use only 70% of your astigmatic diopter for the treatment, because the rest will be taking care of the coma, and that is a rough estimation. So I cannot stress more the importance of the posterior curvature in your assessment and in your treatment planning, and that has been shown, like here, that you have almost 1 diopter difference just by the change of the posterior surface. Tomography or ocular wavefront. Here we have Bruce Allen's study, I think is a landmark study, excellent study, showing that with the new tomographers, where you can get a more reliable wavefront map that you can base your treatment on, the results are fantastic. And this is with the Peramis ocular wavefront analyzer. In the beginning, when we used to have the earlier system, the Zernike system and all the other systems, the Chernik from Wavelight, all these systems had incorporated faults specifically when they are mapping highly aberrated corneas. But Peramis, the pyramidal system, has a lot of advantages on actually getting a more reliable map in highly aberrated corneas. I think I have to stop, or should I continue? I have another 2 minutes. Okay? If I can have it. And this is all, so simultaneous or sequential. Again, a big talk. These are the pros and cons. Simultaneous PRK. Usually when you do it at the same time, you have a more treated area, and in one procedure you have less risk of complications. When you do it sequentially, you remove, first of all, some cross-linking tissue that you have already cross-linked 6 months again, in the past, but you can have a better high-order aberrations correction. My question is, when? When is the best time? And I will try to just raise some problems with this. I'm just going down to show you one slide and finish that. This is the maximum flattening with patients that we have follow up to 10 years. And you can see that we can get, with the PRK cross-linking, the maximum flattening goes on up to 10 years, and we have about 3% of hyperopia induction of more than 2 diopters. And this is an alarming effect. This is a study, an ongoing study. We will have the results in a year time to show you in a more appropriate paper with almost over 70 cases. So watch out, because in some of these patients that we are doing PRK now, maybe in 6 or 7 or 8 years, you may have even 3 or 4 diopters of hyperopia postoperatively. And this is something to worry. We don't see that in the standard cross-linking cases, but we see it in PRK cross-linking cases. You can see even the change in the thinnest, 1.5 change in 6 years follow-up, if you compare to 8.5 microns in PRK cross-linking patients. Thank you very much.